It's still morning in Seattle. It's 11 o'clock. I got the topic, which was pretty broad-based, and I thought that probably the best way to, or the best topic to talk today about is just looking at the approach to vesicoureteral reflux, instead of maybe at the end just talk a little bit about the surgery for reflux, because the surgery for reflux is successful. It doesn't matter what type of operation you do. They're all pretty successful in fixing the problem. I think the concept of when do we operate and why do we operate is probably the more important one, because when I look at vesicoureteral reflux, I did my fellowship at the University of Toronto at SickKids in Toronto, and by the time I got done with my fellowship, I probably did around 500 ureter reimplants in 2 years. Today, in my division, we hardly do 20, maybe 30 of these a year. So things have changed over the years. And we've pretty much, this is kind of a saying that was, that really talks to things today, is that we have become experts at the surgical correction of reflux. So when you really look at reflux, the first thing that people did is try to fix it. And so we've been very successful in fixing reflux. Most of the operations that fix reflux are successful 96 to 98% of the time. But we haven't really stressed or understood the natural history and the true clinical significance of reflux. And I think what has happened over the years is that we've gone to the point where we're now looking at more of a risk-based approach to vesicoureteral reflux, really fixing it if it's needed and it's clinically significant. When we look at the journey of vesicoureteral reflux, I mean, the first operations that were performed for reflux was actually not a reimplant. It's actually, they thought that maybe it's the bladder neck that was causing the problem. And there were several operations looking at the bladder neck reconstruction in order to prevent reflux. And then Politano Ledbetter did the reimplant. But then after these operations were devised, Smelly from England was the first one to report in the 60s that, you know what, there's a pretty high spontaneous resolution rate of reflux, and we don't need to operate on all patients with reflux. Moreover, low-dose antibiotics are helpful in reducing the risk of urinary tract infection and also reducing the risk of scarring. And we also know that prophylaxis is a pretty good way of preventing urinary tract infections. And then in the past, surgery was reserved to only if reflux did not resolve over time. And over the years, we tended to overtreat reflux, mainly to avoid undertreating and preventing the complications of reflux. So what we do know over time is long-term prophylaxis may or may not be beneficial. There have been several reports that have shown maybe prophylaxis does not reduce the risk of recurrent urinary tract infections compared to patients that do not receive antibiotics. And reflux is an independent variable, may not represent the risk of renal scarring. And I'll talk about that a little bit more, that the risk of renal scarring may depend on the degree of reflux, but it also may depend on other factors such as voiding dysfunction. And then when you look at the randomized trials that were performed, they're all pretty much flawed because the selection of patients was not the right selection of patients. We do know that, and those are studies from the early 2000s, that renal scarring occurs in around 15% of children with reflux after a febrile urinary tract infection. The risk of hypertension and chronic kidney disease is around 20% for hypertension and 10% for chronic kidney disease. We know that we have reduced the risk of chronic kidney disease due to better treatment of acute infection, and especially reduce the risk of hypertension just because we reduce the risk of scarring. But there's quite a bit of variation in management. There's already no consensus as to what is the best way of managing patients with reflux. And there are several risk factors that we have to consider when managing patients with reflux. What is the age at the time of infection? For example, an antenatal diagnosed reflux is treated totally differently than reflux that is diagnosed after urinary tract infection. What type of infection did the patient have? Was it the lower urinary tract infection, upper urinary tract infection? We talked about antenatal diagnosis. Is there scarring or is there dysplasia of the kidney? Because if it's dysplasia, is something that they were born with it and not necessarily due to the infections. Single system versus duplicated system, bladder dysfunction, the grade of reflux we talked about. And then I think we also need to rely on the family's reliability and compliance in management, and then categorize those patients into high risk that may require surgery and low risk that can be watched with or without antibiotics. I think we need to understand that the primary aim of managing reflux is to decrease the risk of febrile urinary tract infections and to prevent renal damage. So what about evaluating patients with reflux? There are several recommendations in the evaluation of febrile urinary tract infections. The most common ones are the AAP guidelines and the NICE guidelines in the United Kingdom. The NICE guidelines go up to the age of 16. The AAP guidelines are for ages 2 to 24. With the AAP guidelines, they recommend ultrasounds on all children after a febrile urinary tract infection, and then the renal bladder VCUG if the ultrasound is abnormal, or if they develop recurrent febrile urinary tract infections. The NICE guidelines, on the other hand, are a little bit more conservative in that they will get an ultrasound only if it's an atypical non-E. coli urinary tract infection or recurrent UTIs. They will also get a DMSA scan if it's an atypical UTI, and a VCUG if the child is under 6 months of age or they develop a recurrent UTIs or atypical urinary tract infection. So I noticed those two guidelines are a little bit different. They're somewhat similar in that a VCUG is reserved for kids that have recurrent urinary tract infection or have either an atypical urinary tract infection or an abnormality or renal bladder ultrasound. I just briefly would want to discuss another approach of evaluating kids with febrile urinary tract infections, and that's what is called the top-down approach. So basically, instead of getting a VCUG on kids with febrile urinary tract infections, getting a DMSA renal scan, and if there is an abnormality on the DMSA renal scan, either scar or evidence of pyelonephritis, then get a VCUG. And by doing the top-down approach, the yield of the VCUG is much higher, and you potentially are evaluating kids that have had a clinical significant infection, such as a kidney infection. Now, as far as the role of prophylaxis, I think the important factor that we know is that basically reflux by itself does not cause any damage to the kidneys. It's a urinary tract infection that causes damage to the kidneys. So the idea is preventing febrile urinary tract infections and therefore preventing renal scarring. And it's kind of unclear if new scar is preventable. When we look at the RIVER study, the RIVER study is a study that was performed in the United States. There was a randomized control study of patients receiving prophylaxis and not prophylaxis with reflux. When you look at prophylactic antibiotics antibiotics had approximately 50% chance of reducing the risk of urinary tract infection, but there was no change in the degree of scarring, so it did not seem to reduce the risk of renal scarring. On the other hand, the Swedish reflux trial clearly showed that by treating the reflux either with endoscopic treatment or antibiotic prophylaxis, that you do reduce the risk of scarring. But on the other hand, it's really unclear if the effect of reflux are modifiable. When you look at the end-stage renal disease registry, there has been a decrease in the rate of pyelonephritis associated in the end-stage renal disease, but still reflux nephropathy is the fourth most common cause of end-stage renal disease in children. And so question that comes out of that, did you really reduce the risk of UTI or scarring in the kidney that lead to end-stage renal disease? This is the RIVER study, which is a randomized control study. They looked at 607 children with febrile urinary tract infections that had the vesicoureteral reflux. And what they did find is that antibiotic prophylaxis, and they use Bactrim as prophylaxis, does reduce the risk of recurrent urinary tract infections. The patients that benefited the most from antibiotic prophylaxis were those that were mostly girls, and then mostly the low-grade reflux and that mostly because most of the patients that were enrolled in the study had low-grade reflux and the bilaterals. But they did not see any difference in renal scarring rate with patients receiving prophylaxis, and note that did not receive prophylaxis. So the ones that benefit the most were girls and those patients that have bladder and bowel dysfunction. So bladder and bowel dysfunction is a risk factor by itself, and I think probably one of the most important cases of managing vesicoureteral reflux is to actually manage the bladder and bowel dysfunction, because that allows for better resolution of reflux and also allows for decreased risk of scarring. Those are the different studies that this is from the Cochrane analysis. And when you look at that, you see that when you look at studies that have a low risk of bias, basically that those are pretty well performed studies. Overall, antibiotics do reduce the risk of prophylactic antibiotics do reduce the risk of recurrent urinary tract infection. But on the other hand, this is basically what the AAP guidelines came out of, because they used studies that had a very high risk of bias. And when you look at all these studies placed together, antibiotic prophylaxis does not seem to reduce the risk of urinary tract infections. So overall, I think looking at studies that are of high quality, like the ones up here, antibiotics seem to reduce risks of febrile urinary tract infection in children with vesicoureteral reflux. As far as scarring is concerned, it's a little bit more controversial. When you look at new renal scarring, there may be a benefit with antibiotic prophylaxis, may reduce, but you notice it crosses the number 1, so that the overall cumulative function does not seem to correlate with the risk of renal scarring. On the other hand, if you look at all comers, basically patients that have new and progressive abnormalities, it looks as if antibiotic prophylaxis may be able to, or may reduce the risk of either developing new, or if they have a renal scarring, developing progressive scarring in the kidney. This is from so as I stated, the RIVER study did not show a difference in the treatment group versus the placebo group in the risk of scarring. On the other hand, the Swedish reflux study did. And if you look at the reflux study, girls were more likely to be affected than boys were. But when you do either prophylaxis or endoscopic treatment, you do reduce the risk of scarring significantly. And they looked at grades 3 to 4 vesico-ureter reflux. And you notice that there is an increased risk of scarring in kids that do not receive prophylaxis or have not been treated with endoscopic treatment. This is another cross-sectional studies that basically stratifies grade with the risk of scarring, and the risk of scarring is greatest if the grade of reflux is higher. So the grades 4 and 5 have a significantly higher risk of scarring than grades 1, 2, or 3. The problem with antibiotics is the resistant patterns. When you look at the RIVER study, 63% of their patients develop resistance to Bactrim. And the risk of resistance with antibiotic prophylaxis is 8 times normal. So that's something to consider when you treat patients with antibiotic prophylaxis, is that the resistance profile is pretty high. So when you look at renal scarring, the risk for scarring of the patients with younger age groups, those with recurrent febrile urinary tract infections, and the higher grade reflux. So in conclusion, we do know that antibiotic prophylaxis most likely reduce the risk of febrile urinary tract infection. The patients that benefit the most are girls and those with bladder-bowel dysfunction. That antibiotics do not alter the scarring risk in general, except in this subpopulation of girls, younger patients, and grade 3 to 4 vesico-ureter reflux. So as far as the guidelines are concerned, the recommendations are to treat with antibiotic prophylaxis in kids that are young and the higher grade reflux, or kids that have bladder and bowel dysfunction, and optional all other groups of patients. Renal dysplasia is a congenital abnormality of the kidney. A lot of kids we know that are with antenatal hydronephrosis have high-grade reflux, and those kids with high-grade reflux have a higher rate of renal dysplasia and abnormalities, even severe abnormalities in the kidney with grades 4 and 5 reflux. This is not modifiable. You cannot change that. They actually are born with this condition. We talked about voiding dysfunction reflux. I think from my standpoint, every patient that is diagnosed with vesico-ureter reflux should be assumed to have a lower urinary tract dysfunction and should be treated that way. We do know that lower urinary tract dysfunction increases the risk of febrile urinary tract infections. So putting those kids on prophylaxis is a good point, and treating the febrile urinary tract infection even before you perform surgery. We do know also that the success of surgery is lower if the bladder bowel dysfunction is there. So your success, even if you're thinking about surgery, success of surgery is higher if you treat the bladder bowel dysfunction. It's really important to treat bladder bowel dysfunction before surgical correction of reflux. And this is from the the Swedish reflux trial study, again showing that when you have normal renal bladder function, the rate of reflux resolution is higher. On the other hand, if you have voiding dysfunction, the rate of resolution is lower, and the rate of renal damage is higher with patients with voiding dysfunction at presentation and at follow-up. So I can't stress more the importance of treating avoiding dysfunction in all patients with vesico-ureter reflux, because it helps in resolving the reflux, but also it helps in reducing the risk of renal scarring. And those are some other of the studies that have actually shown that if you look at patients that have bladder and bowel dysfunction reflux, rate of resolution 31% with bladder bowel dysfunction versus 61% all comers without bladder bowel dysfunction. Same thing with endoscopic surgery, not open surgery, but endoscopic surgery. The success of endoscopic surgery is around 50% we have bladder and bowel dysfunction versus over 90% if you did not have that. There are different calculators that are available online. This is a Boston Children's calculator where you pretty much put in all these parameters. You can get it from the Boston Children's website, and they can calculate the rate of resolution, of timing of resolution of reflux. There's also it's an app called iReflux, which basically I use it quite a bit for discussing risk of urinary tract infections with families. You can plug in their patient age, gender, the degree of reflux, and the system will then calculate the probability of having a breakthrough urinary tract infection. And that this is a good way to counsel families as to the probability of febrile UTI, depending on the degree of reflux and also different parameters. It's important that the kids with reflux be followed long-term, both for the risk of hypertension and the risk of renal disease. We refer most of our patients to nephrology and have nephrology follow them, and also talk to families about when they do their physical examination on a yearly basis to check for protein in the urine and to evaluate their blood pressure. As far as antenatal hydronephrosis, it's a little bit different. With antenatal hydro and reflux, there's a very high likelihood that the reflux will resolve spontaneously. A lot of these patients are males, and so the risk of scarring is small, except that they are born with renal dysplasia. So a lot of these kids with high-grade reflux have renal dysplasia, but the risk of urinary tract infections is pretty small in the antenatal hydronephrosis. So a lot of times with these kids, we can take them off prophylaxis and just watch them conservatively. We try to put them on prophylaxis for the first year and a half of life, and then take them off prophylaxis after that. This is one of the algorithms that we use with antenatal hydronephrosis to put them on prophylaxis if the hydro is severe. But if it's low grade, we would not get a VCUG and only get a VCUG if they develop a high grade, if they have high grade hydronephrosis. Siblings, what we would recommend is just getting an ultrasound on siblings and not evaluating them with a VCUG unless they develop a febrile urinary tract infection. So in summary, UTIs in children are common. They're higher risk in children with bladder bowel dysfunction, younger age. Those are recurrent infection. Always review bladder and bowel dysfunction in patients with reflux and manage it, because resolution of reflux is higher if it's managed adequately. Antibiotic prophylaxis can reduce the risk of febrile urinary tract infection, but again, there's a cost of antibiotic resistance, and so it's important to think about that. Surgical correction reduces the risk of febrile urinary tract infection. Again, you have the low cost of an obstructive risk related to surgery. And then when we look at the majority of patients, renal scarring is not altered by any of these types of managements. So for grade 3 and higher reflux, prophylaxis may be beneficial. In the males with antenatal diagnosed reflux, antibiotic prophylaxis may not be necessary. And then discontinuing antibiotic prophylaxis is reserved for those kids with breakthrough infections. And that may be the most cost-effective way of treating the reflux. And so in our practice, we would not repeat a VCUG if we have determined that we are going to stop prophylaxis. So for example, if a patient is seen for vesicoureteral reflux, we put the patient on prophylaxis. And then once the patient is toilet trained, we discontinue antibiotic prophylaxis. We would not repeat the VCUG unless that patient develops a febrile urinary tract infection. They do develop febrile urinary tract infection. That's when we would repeat avoiding cystoid gram. I think it's important to really involve the families in the care of these patients and their management. And this is an example of an algorithm that we have created for our primary care physicians, looking at reflux and really risk stratifying, because if there's grade 1 or 2 reflux, those are low risk. They do not need antibiotic prophylaxis, and they should be referred to urologists only if they develop a recurrent febrile urinary tract infections. On the other hand, if you have a grade 4 or 5, those are high risk, and they should be referred to urologists for evaluation management. The intermediate risk can be placed on antibiotic prophylaxis, and then we would discontinue prophylaxis after toilet training and only treat those with breakthrough urinary tract infections. So realistically, they can be managed by their primary care physician and referred to us only if they develop a breakthrough urinary tract infection. So briefly, I'm going to talk about, and I understand there's a case that's being presented, but I'm to talk about the different types of reimplantation. The reason I did not really concentrate on these operations, because most of these operations are successful in treating the reflux. The ones that we perform more commonly are the cross-trigonal reimplant, is basically mobilizing the ureter. Important here is we keep a cuff of the mucosa around the ureter, and then suture the cuff of mucosa to the bladder distally, doing a cross-trigonal ureter reimplantation. This has a 98% success rate. This is a procedure that's most commonly performed in bilateral reflux. There is the Politano-Ledbetter reimplantation, which is basically mobilizing the ureter and then taking the ureter outside the bladder into a new hiatus and tunneling it in the submucosal tunnel. The problem with this, as you notice, the peritoneum is right there. You have to be very careful that you don't snag or pass the ureter into the peritoneum, then causing an obstruction at this level. And that's a pretty common, not a common, but it's a complication that does occur with Politano-Ledbetter. You have to be really careful not causing that. The cross-trigonal reimplant, on the other hand, relies on the actual hiatus, so there's no risk of causing obstruction at the hiatus, and you're creating an adequate tunnel because you're doing cross-trigonally. There's a Glenn Anderson reimplant technique, which a lot of places use this technique. It's pretty much mobilizing the ureter and then creating a tunnel either distally or we can separate the detrusor muscle, mobilize the ureter more proximally and create distally to reimplant the ureter. The extravesical approach is a way that has been popularized since the 1980s. We tend to do them extravesically for unilateral reflux. The bilaterals have a higher risk of urinary retention after surgery. And so I've not done a bilateral extravesical reimplant open for quite some time. The idea here is to create a tunnel extravesically, advance the ureter, and then do the reimplant extravesically. But now with robotic reimplantations, our robotic surgeons are pretty comfortable in doing bilateral reimplants robotically. They do have a risk of urinary retention after surgery, but the risk is small. It's less than 4% chance of that happening, and most of it is transient. And I think with the robotic surgery, the dissection is done in such a way that the neural bundle and neurovascular bundle around the ureter is not really dissected, whereas with the open bilateral, it may be affected, and that may be the reason why with the robotic reimplant or laparoscopic reimplant, there's less chance of injuring the neurovascular bundle. As far as tapering is concerned with Megaureters, there are different techniques. All of them are pretty successful. This is called the Kalachinsky technique, where you basically obliterate part of the ureter and then fold it over like that. Or an excisional technique like the Hendron maneuver, just cutting the ureal wall and suturing it and reimplanting it. One of the theories that a lot of people have is a lot of people question the need to taper the ureter because this kind of tapering happens anyways if you put the ureter in the submucosal tunnel. A lot of people today are not tapering the ureters as often as they used to in the past. So if the ureter is not that dilated, so we not taper it and just put it in the submucosal tunnel. Thank you, everyone. I think we have time for questions and also a presentation, I guess.
Thank you so much for presenting, Dr. Merguerian.